difference between a caput and cephalhematoma. Remember, I told you there are a couple of things you have to keep in mind. What it is, which one is swelling, which one is bleeding, which one crosses the suture lines, which one does not, and how long they take to resolve. Okay, those are going to be your main points. We covered that, talked about this. There's our fracture. I think we left off. We didn't get that far. I think we left off here.
That's correct.
Yeah? Okay.
Yes.
Yes.
Okay. All right, so we'll carry on from here. So the umbilical cord, as you know, and I'm just going to remind you, I mentioned this yesterday with the students after when we spoke during office hours. Make sure you read the questions carefully. I know this is not about the umbilical cord, but it just reminded me that there was a question on the first unit exam that asked about umbilical cord vessels. And I am pretty sure that most of you who answered it incorrectly because you didn't read the question. You didn't fully read the question. So 2 arteries, 1 vein. The question listed the vessels as 2 veins and 1 artery. And I'm sure that's why most of you got that incorrect. So just a reminder to make sure that you're reading the questions. Okay, 2 vessel cords, 2 vessel umbilical cords are associated with cardiac and renal anomalies. So you can, when a baby is admitted to the nursery, you will inspect the umbilical cord and look for those vessels. They are visible and palpable. So let's say you have a patient, baby is born, 2 vessel cord. What does this mean for the rest of your nursing assessment? That's a question for all of you. Feel free, chime in or answer in the chat box. What does this mean for your the rest of your assessment?
Professor, I missed
You're
your
going to do a...
Can you say one more time? I'm sorry.
You are the nursery nurse. You are admitting a baby. You examine you're assessing the umbilical cord. You examine the cord and you see that it's a 2 vessel cord. My question to you is, what does this mean for the rest of your assessment? What does this mean for your care of this baby?
You're going to want to do a more focused assessment on the cardiac and renal systems.
So what does that mean? I want you to be a little bit more specific. So yes, but I want you to just drill that down for me.
I mean, I guess additional labs and monitoring.
Even before you go to that, so cardiac wise, think back on you. So cardiac wise, which vital sign did I tell you we mainly don't do in the newborn nursery?
Blood pressure.
Blood pressure. So that's you would start right there, right?
Mm-hmm.
This baby might have an undetected defect. So start with, and the reason I'm saying it that way is think of what's easiest for you to do, right? You're going to do vital signs. So you would get a blood pressure on this baby. Thinking about your shunts, remember this baby's transitioning from fetal circulation to extrauterine circulation. You would get blood pressures on all 4 extremities. And you make a note of that. Which extremity obtained, what the blood pressure was for each extremity, because you're looking for differences. And I'll talk a little bit more about that as we go forward. Okay, so a more detailed cardiac assessment. What else might you, just thinking cardiac first, what else might you drill down your assessment to?
Cardiac output? No.
But what are you, your assessment, what you're doing?
Pulse rate?
So you would have done, you did you have your vitals, but what else?
Okay.
What would you do on an adult if you're doing a cardiac assessment on an adult?
You listen to the,
Auscultate.
you listen to heartbeat sounds, like any abnormal sounds.
Auscultate.
Okay, so a more detailed assessment of your heart tones, right? Of what you're hearing. So that's a different thing than the rate,
Mhm.
okay? The way it sounds is one thing, the rate is another, right? So yes, a more detailed cardiac assessment. Yes, Jocelyn, you need to check capillary refill. Now, granted, your baby might still have some acrocyanosis, but you want to see, you do that, you document that now. This is what I'm getting for capillary refill at 9 a.m. Let me see what I get at noon. Let me see what I get at 3 p.m. Is it improving? Is it still the same? That speaks to cardiac function, right? So is this baby cyanotic? Is there central cyanosis? If you're checking for central cyanosis, where are you looking? Easiest place.
Lips.
The lips.
Right. So you're looking for circummoral cyanosis, right? Checking the lips for cyanosis. That's the easiest place to look for central cyanosis. So you would check the femoral pulses, capillary refill, full assessment of the heart tones, what it sounds like, the rate, yes, blood pressures on all four extremities. You would also consider doing pulse oximetry on each extremity, okay? I want you to think about the things that you can do. You start simple, work your way to complex, but also think about the things that you can do within your scope of practice. So this baby will probably need an echo. This baby may need some additional studies, but we always do, as I've told you, you do everything that you can within your scope of practice before you kind of hand off the assessments. Okay, and then what is going to be your main assessment for renal? Don't overcomplicate it. Yes, just output.
How about
Dividing the urine?
urine in the diapers? How many wet diapers a day?
Right, how many wet diapers? How frequently is this baby voiding? And a sense of how much, how wet the diapers are. So you remember, you weigh a dry, clean diaper, then you weigh the baby's diaper and you subtract the weight, and that should be basically how many mLs of urine is in the diaper, okay? Check the baby's, you would also follow the baby's daily weight, yes, okay? Which we tend to do in the nursery anyway. Okay, so that's how you guys have to start thinking, right? You got a 2-vessel cord, cardiac or renal anomalies. What does this mean for me? What do I need to check? What do I need to follow up on, all right? Okay, Wharton's jelly, that is the gelatinous substance that surrounds the umbilical cord, and it does reflect, it's reflective of intrauterine nourishment. So if you have a baby that has a shriveled up looking cord, that should be concerning, and that should tell you something about how well nourished that mom was throughout the pregnancy. So don't just say, oh, it's the umbilical cord, I don't have to pay attention to it. Everything is telling you something. Everything tells you something. If the umbilical cord is stained green, has a greenish discoloration, that is associated with fetal distress. And that greenish discoloration will be caused by the release of meconium prenatally. So the only time a baby releases meconium before delivery is if that, a fetus, is if that fetus was in distress. And we will talk more about that when we get to complications and what all of that means. But for now, keep that in mind. If you have an umbilical cord that is stained green, that's a huge red flag to you. This baby had distress in utero, particularly if it's really stained. I mean, if you look at the cord and it is truly green, you know this baby was in distress, was in significant distress, and was in distress for a long time.
Professor,
Okay.
are we talking about
Few hours of meconium in the amniotic fluid is not going to stain the umbilical cord green. It's not going to stain it, you know, a deep green. All right. Okay. Let's talk about these extremities. I think that's next. All right. So we talked about the head, the face, the neck, clavicles, umbilical cord. So extremities and the spine. And then we need to talk about measurements and systems. All right. So the extremities. Check your muscle tone, which was already checked, right? 1 minute APGAR, 5 minute APGAR, but you're always checking that. Remember, when you're talking about muscle tone and movement, we're not just looking at musculoskeletal, we're also looking at neurological status. So tone, movement, symmetry, assessing for fractures, particularly the clavicular fracture. Hands and feet, note the positioning. Check for any extra digits. Also check for webbing. Just those fingers open and just make sure that they're separated, okay? Don't pull them, but you just want to make sure there's no webbing between the fingers. Occasionally you will get a baby with webbing between the fingers or between the toes. So you just want to make sure that they're separate, that they are separated, right? And sometimes it's a very thin membranous webbing. So you don't want to pull them apart, but you just want to separate gently to make sure that they can be separated. So check for any extra, whether they are tags or fully formed fingers. Pediatric orthopedists will be consulted, and then a decision will be made based on the parent's preference. So you might have an extra digit that is semi-formed. It might just have soft tissue. There may be ligaments. There may be ligaments and bone. There may be, you know, so a decision has to be made depending on how fully formed it is and what the parent's wishes are. Don't make the assumption that all extra digits are removed. They're not, okay? Some parents prefer to keep that extra digit there. All right, simian creases, we no longer use that term. The term is palmar crease or creases, although on one of my slides you will see simian crease, but it's an older slide. The current term is palmar crease, and so I'm going to speak about that as we go forward. I'll talk about all these other, yes, as we go forward. Okay. So when we talk about palmar creases, what you're really looking for is the crease, if there's a crease that goes across the palm, straight across the palm, like this one. This is what we used to call a simian crease. We now just refer to as a palmar crease. These are associated with trisomies such as trisomy 21, Down syndrome. Now, associated with doesn't mean that everyone who has a palmar crease has Down syndrome. So please don't go around diagnosing people. That can be not a good safety measure for you, okay? There are plenty of people walking around New York City with palmar creases who are perfectly fine, right? It's just that we see a higher incidence. in patients who have trisomy 21. Okay, so you definitely want to take note of that if it is present, and of course which hand it is on. Developmental dysplasia of the hip, very, very important. I'm going to, I think we'll have enough time. I'm going to show you a video later. There's a part of the video that explains in detail how the hip forms. And so I want you to pay attention to that. I think it'll make this a little bit more clear. So remember that the hip, like the shoulder, are ball and socket joints. So you need both pieces to form and to form together, right? So you need, the hip joint needs the structure of this for the acetabular limb to really form well, okay? So what we're checking when we do the Barlow's test and the Ortolani's test is we are checking for hip stability. Whoops, for hip stability. So we're checking to see, I'm gonna minimize this for a minute. We're checking to see if the head of the femur, if it slips in or out of the joint. So it should be, this is normal, it should be firmly planted in the joint. If it slips out, that is concerning, okay? So you always, when you're doing assessment of the hips, whether or not your facility has the nursing staff do the Barlow's and Ortolani, some places the pediatrician or the nurse practitioner will do this. Some places the nurse does it. But either way, this is what you're testing for. But you're always looking at the hips, how they're positioned, and leg length. If a baby has developmental dysplasia of the hip, you can see how the head of this femur is out. Is this leg, this right leg, is this leg going to be longer or shorter when you're assessing this baby?
Shorter.
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 It's going to be shorter. So you need to make sure that when you're assessing, you're looking at the, not just at the length of the legs, but you have to turn the baby over, stretch the legs out, and check for symmetry of the creases. The creases should be symmetrical. Okay? So you have to turn the baby over, stretch the legs out, look at the leg length, and look for symmetry of the gluteal and thigh creases. And the video will show how this is done as well, so you'll be able to see it. So babies that have developmental hip dysplasia, they will wear a Pavlik harness. I'll talk a little bit more about that when we get to complications. It may look like a uncomfortable kind of a thing, but it really isn't. What the harness does is it holds the hip in place so that as the baby is growing, the joint grows in place and it doesn't, the head of the femur doesn't slip in and out. So moms take this off, you know, maybe once a day, maybe twice a day, skincare, bathing, that sort of thing. But the babies really do get used to having it on, and it really doesn't cause much discomfort. Okay, sacral hair tufts. So we need to make sure that we examine this baby's back. So while you're doing this, you're already checking the back, you will check the spine, and you especially check the lower spine. Okay, so when you're doing your assessments, you have to try to think of how you're going to do things in an orderly manner, in a sequential manner, so that you're not flipping the baby back and forth and back and forth. The same way you would try to do with an adult. You try to, you know, have a patient undress once, and you do all of your assessment on one particular area of the body at a time, so you'd get everything done. It's kind of similar to this. So you check the spine to make sure that it feels like it's in alignment, and then we check The lower spine, we're looking for any dimples, sinuses, hair tufts, or skin discoloration. Now, I am not saying that every baby with a hair tuft has spina bifida. There are some families that everybody in the family has a sacral hair tuft. That's just the way the whole family is. Does not mean that they have spina bifida, but it can be indicative of spina bifida occulta. So I'm just gonna skip forward here. So this is spina bifida occulta. There's a significant portion of the population that is walking around, running around very happily, don't even know that they have spina bifida occulta, that those lower vertebra did not fuse. It doesn't interfere with their lives. They're running, they're jumping, they're dancing, they're having a good time. They don't even know it, okay? But a fair number of them, if you look at that, if you do an examination, you will see a hair tuft or a blemish at the lower spine, okay? So it is something that we should pay attention to. But what we're really concerned about is meningocele and myelomeningocele. When you get to pediatrics, you're going to spend a lot of time on spina bifida, so I'm not going to go into it a lot other than to say these are what we are concerned about. So checking for a hair tuft, dimples, and if you see a dimple, you have to do just this, separate the skin and make sure it is closed, okay? So dimples, these are really fairly deep. This one is pretty deep. This is what a myelomeningocele. Yeah, that's a myelomeningocele. That's what it looks like. It is detectable on ultrasound. So again, one of your many neural tube defects that you will talk about more in peds. So let me ask you, with a meningomyelocele, how will you address that lesion? What are you doing for that lesion? What are you doing for that area? Obviously, you're positioning the patient prone, right? You're positioning the baby prone. What are you doing with that?
Wrapping around, is it possible to wrap to prevent any laceration and, I mean, the fear that the cerebrospinal fluid can leak out?
So you're saying wrap it, to put some sort of wrapping?
Around, yeah, something like, I mean, I don't know.
Okay, so what about the rest of you? I wasn't planning to put this on the exam, but now you're making me think about it.
Oh,
You're
no,
so
no,
good.
no. No,
In order
Professor.
to answer that, I think we need more information on what it actually is. I mean, there's
No,
nerve
it's a,
stuff there.
well,
Okay.
it's a, so I'll put the picture back up so that you can see it, but it's a meningomyelocele. So there's a membrane.
And how has that? Like, what's the ultimate care for that? Does it go away? Does it not go away?
But that's not what I'm asking you. I'm just asking you, what do you do? This baby is born and is placed, you're in the delivery room, the baby is born and is placed on the radiant warmer. What do you do about this? Obviously, as I said, you position the patient prone. You're not going to put the baby on it, right? What else will you do for this?
I mean,
Knowing-
it would be protected somehow. How? I don't know.
You know how? That's what I'm asking you. What? And you guys don't overthink this. Don't
With a
overthink
diaper?
it.
With a diaper?
So you wouldn't, but what do you, so, okay.
We
So
are
you know
wrapping.
this is the base of the spine. This is a neural tube defect. It's at the base of the spine. There are nerves within this sac. So what I'm getting from you is that you want to keep it
in place.
clean, and you want to keep it safe, right?
Yeah.
Okay, so,
Professor, wouldn't since all the nerves are there, like if you compress it, isn't that going to cause pain?
but we're not compressing it. That's
No.
why we put the baby prone, right? We put her prone, here, her or him, I think it's girl. We put her prone. So we're definitely not going to compress it. We haven't even put a diaper on. Well, actually, there is a diaper there towards the, mainly towards the front and roll back so that it does not touch this. So I'm asking you to think about what you're telling me about keeping it
Safe.
covered, keeping it safe, keeping it clean. So I see, Ruth, you wrote here, keep it sterile. How will you do that?
I'm not really sure, but I just know that I don't want to. I
You
don't want
know
to.
that.
I don't want anybody to
No.
touch it.
We
No,
put,
I'm not going to let you get away with that. You guys know, this, you wrote it. So I know that you know this. And I know that all of you know this. You're just not using the knowledge that you have. If you need to keep something sterile, you guys did one here in fundamentals. This was your skill. If you want to keep something sterile, what are you putting on it?
Dressing.
sterile gauze.
You're dressing.
Sterile dressing.
Yes.
Okay. Are you putting a dry sterile dressing on this?
No.
Okay, so if you're not putting a dry dressing on it, how you have this package here with your dressing cloths, right? And it's dry. How are you going to moisten it?
You moisten it in saline, you treat it the same as
Okay, so tell me more about that saline.
So you would dip the dressing.
Tell me about the saline itself. You want to
Normal
make sure the
normal
saline
saline?
is what?
Sterile
It is
and
sterile,
normal
and
saline.
it is
Normal
it is-
saline.
It is normal saline, it is sterile, and it is, are you going to take a bottle of normal saline off the shelf and pour it over
No.
your dressing and then put it on here? That's your basic technique. But I want you to think about what I said to you yesterday about this baby's temperature. What did I say to you about the difference in temperature?
Okay.
If you take normal saline off the shelf, what is the temperature of that normal saline?
20,
What did we determine the room temperature was
22,
yesterday?
22.
So we said 22, 24, somewhere around 72,
75,
75
yeah.
degrees. You're going to
Yes.
pour this on the sterile gauze and put it on this baby. What's going to happen to this baby's temperature?
Fever, yeah.
It's gonna drop.
And then what's going to happen to this baby's oxygen?
It's gonna
And what's
drop.
going to happen to this baby's glucose? Okay, so I want you to go back. Tell me what you're going to do. What kind of dressing are we putting on? A sterile
Warm.
dressing,
Warm.
warmed, sterile, normal saline. That's what we're using.
Professor, but then it's gonna get cold, right? So do you keep the baby
But remember, where did you put your baby?
in a heated?
Therapy.
Either on the radiant warmer or in an isolette.
That makes sense. Yeah, thank you.
Would you also put pillows on either side just to make sure the baby doesn't roll over accidentally on it?
So a newborn is not going to roll. More than likely, she's not going to roll. But you could put a roll around her. It's developmentally supportive. These babies, newborns are used to having the boundary of the uterine environment. So having a boundary around them is very comforting. So even a rolled up blanket would be comforting for her.
What can we do to prevent SIDS from occurring since they are face down?
So as you can see, this baby is on a monitor. She's on a cardiopulmonary monitor. So you'd have this baby on a monitor so that if she has any apnea or any reduction in her respiratory rate, the monitor would alarm. So
Great.
absolutely, you know, this baby's going to the NICU, right? And neurosurgery will be called, pediatric neurosurgery will be called for this baby. So these babies will have series of surgeries. They tend to have, several surgeries, depending on what the, the status is with the nerves and how much trauma has the nerves have sustained. Sometimes these babies are able to walk, sometimes they're not. So it just depends on the extent, okay? But how we take care of this from the beginning is huge, right? That's where it starts. It starts with us from the minute this baby is born.
So I have a question. So you say that the mom knew it, right? Baby had this. Is it
It is
detectable?
detectable on ultrasound. You can see this.
Then when this baby, it seems like it's impossible, the vaginal delivery. Is it possible?
Everything is possible. Usually when we know that these babies are, so I want you to think back on all the things that you've been learning. We would have diagnosed this from all of those prenatal tests, right? The test that determine neural tube defect. So we're going to follow this baby really closely, do a lot of ultrasounds, see how much are we dealing with a meningocele, or are we dealing with a myeloma meningocele, like how, you know, as detailed as we can with the ultrasound. And then usually, yes, these babies are delivered by a scheduled cesarean section. It's already planned. You have extra people here to, you know, to take care of the baby. Yeah. Unfortunately, sometimes you have babies that have congenital anomalies that the moms don't, for varying reasons, don't have prenatal care. And so they deliver vaginally, and you just have to do the best that you can.
Okay, thank you.
Okay. So this baby would not, from what I can determine, wouldn't need phototherapy for the meningocele. But she will definitely need
A warmer.
additional care. I mean, because you think about it, especially with this size lesion, this is a baby that you will keep prone very often. You're going to keep her prone a lot. So what does that mean for the pressure on her knees? Right? So you have to be, you know, that has to be a part of your care, checking for skin breakdown and so on with this baby. Okay. So this baby more than likely would be gavage fed or fed with IV fluids initially, parental nutrition or gavage feeding. And then depending on how the baby does after the first surgeries. You didn't cover gavage feeding in fundamentals? Nothing about
I don't
tube feeding?
remember, actually. I remember the parental, but I don't remember the gavage. I don't even.
Right. Same.
So anyone else, gavage feeding? No?
Gavage.
No, that wasn't covered.
Okay, all right. So thank you for stopping me because, yeah, okay. We'll get to it. Gavage feeding is basically through an OG tube, through an orogastric tube. That was what I was referring to. It can be through an NG tube, a nasogastric tube, or an orogastric tube feeding, all right? Okay, so neurological system, we are assessing reflexes. Whenever you're assessing reflexes, you're assessing whether or not the reflex is there. Is it strong? Is it weak? And symmetry. So when you do like the palmar reflex, you're checking left and right, okay? If the reflex is something that should be symmetrical, you have to check both. You can't just check one and say, oh, it should be there on the other side, all right? Because remember, there are two sides to the brain. There's no guarantee that both sides are working. So you're always checking for symmetry. Sensory assessment, as I mentioned, looking at the face, this is referring mainly to eyes and ears and the nose. So where are the eyes placed? What is the appearance? Are they symmetrical? Other neurological signs, is this baby jittery? Is this baby tremulous? Is this baby seizing? Is this baby irritable? Is this baby crying? Paying attention to the cry. A high-pitched cry is indicative of a neurological issue. Now, that issue may be that the mother had a history of substance abuse and now the baby is in withdrawal. Or it may be that this baby has a neurological deficit. Maybe this baby sustained prolonged hypoxia and now has a damage to the brain, right? So a high-pitched cry is indicative of something's not quite right with the neurological system. So you have to pay attention to that. It's an important part of your assessment. All right, reflexes. So the Moro, there is a difference between the Moro reflex and the startle reflex. The terms are used, very often are used interchangeably, but they are two distinct reflexes. Now, it's a fine distinction. So I want you to learn the Moro reflex. I will not ask you about the startle. I want you to know the Moro, but just in case you come across in your reading and you see that, sorry, I forgot to turn my phone off. I just wanted you to be aware of that. Okay, palmar grasp. So most babies, you know, if you can pry that hand open and you put your finger in, they will grasp your finger. Again, you're doing both hands. Is it present? Is it strong or is it weak? Are you getting it the same reaction on the left and on the right? So plantar grasp, it's very similar to the palmar grasp, except with those little toes. The Babinski reflex, sole of the foot, usually we'll use like the edge of a nail. So you stroke the surface, the lateral surface of the foot. And the toe should dorsiflex and the other toes will curl. Sucking reflex, I already spoke about. The rooting reflex, if you touch the side of the baby's cheek, the baby should turn in that direction. The tonic neck reflex. When how can I say this? The baby is supine, if the one arm is extended, the other arm will bend. The opposite arm will bend, the leg will bend, and this leg will be straight. This is commonly called the fencing reflex. The baby assumes what we call a fencing position. So the main ones that I want you to know again are Moro, palmar, plantar, Babinski, rooting, sucking, and the tonic neck.
Professor, sorry, the tonic, now what is this? How did you call the defense?
Fencing, fencing, like fencing.
Okay.
Mhm.
Okay.
Okay, skin. More pictures. All right, so first of all, remembering that the skin is the body's largest organ.
Yes.
First question is the skin intact? So we start from there. I'll remind you again, if the baby intrauterинely was monitored with an internal monitor, you know, you need to check the scalp for lacerations, okay? You know, anything in the history that gives you a hint of where you might need to zero in on, pay attention to that. So we're starting with whether or not it's intact. What is the color? Is the baby pink with acrocyanosis? Does the baby have central cyanosis? What's going on? Is the baby pale? Okay, so making sure that you are specific about that. And then each one of these I will go through, with the exception of this: pressure abrasions from labor and or delivery. This is referring to like the baby that I showed you with the bruised hip from the breech delivery, or the baby with the facial, the soft tissue bruising from forceps, the hematoma from forceps. So any abrasions or bruises from labor and delivery. The rest of them I will show you pictures of. Breast tissue, making sure that we note the number. Occasionally you'll have a baby that has three nipples, so you want to pay attention to that. So how many nipples are there, where are they placed, and whether or not there is engorgement. It isn't unusual to see breast tissue engorgement in a newborn, and that's because of the maternal hormones. So as the hormone levels drop, the engorgement will usually minimize. Hair and nails, more term babies, the more mature baby is kind of typically the longer the fingernails are. So just whether or not hair and nails are present. And then for everything, you're looking at what is it, where is it, how many, what's the color, what's the texture. You know, if you have a baby that has some unusual skin lesion or something, you have to do your best to describe it. So always keeping in mind that someone, if how I'm writing this, would this be clear to someone who is not seeing what I'm seeing, right? You just want to try to describe it as much and as clearly as you can. So lanugo, you know, this is the hair that we see on a fetus and often on a newborn. The babies shed lanugo as they're getting closer to term. The hair on the shoulders is usually the last of the lanugo that is lost. So having just come from psych, what other patients do we see lanugo on?
Anorexia.
Right, your patients with anorexia. Kind of the same thing, soft, downy hair. So milia, we sometimes refer to as baby acne. So it's just the sebaceous glands, and these it resolve without any treatment. Nothing needs to be done for this. Erythema toxicum. That name sounds absolutely horrendous. And I don't know why it was named that way, because this is a very common newborn rash. It resolves without treatment. But when you look at it, it does look pretty, it tends to have like a very, what we call an angry look. So it's red, it's blotchy. You might see it, we usually see this like 24, 48 hours after birth. It's more common on the face and the trunk. So the face, the back, the shoulders, the chest, on the trunk of the body. Although there are these little fluid-filled vesicles, it is not a sign of infection. So the cause is unknown, and it usually just self-resolves within 1 week. Usually by the first week of life, it just resolves and disappears. So that's erythema toxicum. Questions? Okay, good. Mongolian spots. These are bluish, grayish spots that we see they're commonly found on the sacral area, on the hips, the upper thigh. Sometimes you will see them on a wrist or on an ankle on this baby. They are more common in newborns with darker skin tones, and they usually fade by like age 4 or so. They usually fade. Although you will have, you know, sometimes you have an adult that who's, you know, you'll meet who's has a Mongolian spot that never faded. So they look like a bruise, but they are not bruising. They're just considered a birthmark. Nothing to be done for them or with them or about them. All right, let me just answer this question before we go to stork bites. Okay. So I'll answer that after for you. It's kind of a long story. So stork bites, we tend to see these on the back of the neck, sometimes on the eyelids. It's a discoloration that's caused by dilated capillaries. They are flat, not raised, pink. They do blanch. If you press on them, they blanch, and they disappear as well. They usually disappear by maybe age 3. But sometimes the ones on the back of the neck will remain, but the ones on the eyelids tend to disappear by like age 2, age 3.
So what are they caused by again?
Capillaries, dilated capillaries.
Okay, gotcha.
Nevus flammeus, port wine stain. So port wine stains, just what they sound like. These are permanent, dark red, dark reddish, sometimes a little bit purplish. They do not blanch. As I said, they're permanent. They will grow with the baby. Not unusual to see them on the face. Sometimes they start out small. I actually had a nursing student about 3 years ago who she told me that her port wine stain started out very small. And she actually brought me a few pictures of her as a toddler. It was small. And then as she got older, it got larger. Ended up being fairly large. So no, these we will, oh, angels. So angel kisses, Jocelyn, you were referring to the stork bites or port wine stains?
Ooh, the stork bites. My sister was born with one in like between her eyebrows. My mom used to say that it was either, can't remember if it was angel kisses or like like kisses from like Virgin Mary. Very like
okay,
languages.
That's lovely. So port wine stains, we typically, if they are large and depending on the complexion of the baby, you might be able to see them on ultrasound, but there's no specific testing for these. And they are, there's nothing structural or functional that this is an issue, right? It's just aesthetics. Okay, nevus vasculosis, just what it sounds like. These are vascular, okay? These are vascular. So they're commonly referred to as strawberry hemangiomas. They can grow quite large. They consist of enlarged capillaries in the outer layers of the skin. They tend to have this rough surface like a strawberry, and that's what's given them this name of strawberry hemangiomas. We see them very often on the head, a lot of times on the face. They may disappear by early school years, they may not. So this one is on the abdomen. I think this one you can see the texture of it the best, that rough appearance that gives it the name of strawberry hemangioma. This is one on the buttocks, here one on the face, one on the scalp. So sometimes if they are, depending on where they are, if they are blocking the vision. So I took care of a pediatric patient who had a very large one near the outer canthus of her eye. And so that had to be lasered down because it was interfering with her peripheral vision. But otherwise, sometimes they're just left to grow. Cafe au lait spots. Cafe au lait spots are permanent, light brown areas. They may appear anywhere on the body. So again, on our babies, we have to make sure that we examine every inch of that little body. Now, the number and size of cafe au lait spots is very important. 6 or more spots larger than half a cm are associated with neurofibromatosis. Now, associated with doesn't mean if you are assessing a baby and they have 8 cafe au lait spots, that it's not an automatic diagnosis, but there is an association. And so when you have a baby that has these lesions, you need to be very careful about that. It has to be reported and this baby sent for follow-up. So I will show you a little bit more about neurofibromatosis. So there are 2 types. It's a genetically inherited disorder. Nerve tissue grows, the nerve tissue grows tumors. Now, neurofibromas may be benign, but they do cause damage because they grow very large. They press on nerves, they press on vital organs, they press on tissues. So it's an autosomal dominant disorder. I think I have one more picture of the lesions, and then I'll show you the picture of neurofibromatosis, which I will warn you right now is not a pleasant picture, okay? So these are cafe au lait spots. Again, you're counting and measuring them. And this is neurofibromatosis. So these lesions, this patient has them, these are external. This patient has likely just as many internally, large. As I said, they grow. They press on vessels, they press on nerves, they press on vital organs, they press on tissues. So not a lot, quite frankly, can be done about this, but if you know, at least if we know that this is what this baby has, you know, from here when we're counting these lesions, then the baby can be managed accordingly. Okay.
Professor, a person with this, like in this case, do they have a permanent problem and a reduced life expectancy?
It depends on how large. No, it depends on how large the neurofibromas are, where they're growing, which organs they're pressing on. So in terms of surgery and surgical removal, they are going to grow back. So even if they're removed, they're going to grow back. And as I said, you're looking at what this patient has externally. So likely think about the number of tumors internally and that they're pressing on nerves, pressing on vital organs, and so on.
Okay.
Okay. All right, petechiae. So petechiae are pinpoint bruises that resemble a rash. They're actually tiny hemorrhages within the dermal or submucosa. So again, you want to pay close attention to this. Examine your baby every inch of that little body of that skin. So we may see petechiae as a result of pressure during the birthing process. We may see petechiae as because there's an underlying issue an infectious issue, a hematologic issue. There may be an underlying issue. So baby, the long and short of it is, baby should not have petechiae. Okay, if you're seeing petechiae, and an adult should not have petechiae either, actually. So if you're seeing petechiae in the patient, you need to do some investigation into why and what does this mean? What's happening with this patient? Okay. No. Yes and no. So those patients may have widespread petechiae, but there's another lesion that's specific, if I remember correctly, to dengue fever, in addition to the petechiae.
Professor, we talk about petechiae when, at least in the movies, when someone is apoxic, like, right? That they look for petechiae because they were strangled at the scene.
Well, you will see that in the eyes if there's, but it's not. But you're not. It's not the hypoxia that you're seeing. It's actually not the hypoxia that you're seeing. It's actually the tiny hemorrhages. It's the hemorrhages of those very small blood vessels. That's actually what you're seeing.
Oh, okay.
But I'm sure they're not. They're not going to say that. No. Okay. All right. So social adaptation. Okay, so periods of reactivity. Periods of reactivity. So your baby, so we're shifting now to the psychosocial adaptation of our little person. There are periods of reactivity that we need to pay attention to. The first period of reactivity is immediately after birth for like that first hour or so. At this time, the baby is very awake and alert, very interactive, making eye contact, tracking, that sort of thing, really kind of focused in. And then the baby falls into a deep sleep. So that deep sleep will last a few hours, and it's a deep sleep. So sometimes moms will be somewhat frustrated by this period of sleep because they may feel like, oh, the baby was so interactive right after delivery, and now the baby is just like really in a deep sleep and not interacting. It's normal. This is just the period of sleep. So it's a really deep sleep. Then the baby will wake up, and the second period of reactivity may last anywhere from 2 to 8 hours. Now, this is the time that we have to make sure, we may be thinking, oh, baby's 6 hours old, baby's 8 hours old, I don't have to pay attention. No, you have to pay attention, because the second period of reactivity is when babies tend to become apneic. This is when they tend to, if they swallowed a lot of amniotic fluid or blood during the birthing process, this is when they're vomiting. They tend to pass meconium at this time. So they may become, again, they may become apneic. So you have to really pay attention to them at this time. And at this point, the mom is probably tired and resting. So the baby is there in the room with the mom and may have some breathing issues, and she will be sleeping, right? So this is the time, in terms of our nursing care, we have to be aware of that and remember that we need to frequently go in and check on this baby. Okay. So behavioral states. Now, behavioral states. So babies have these 6 behavioral states that they will cycle through from one to the other. They don't jump all over the place. They are pretty much going in order, whether forwards or backwards, but they're going in order. So you may have a baby that's in a quiet sleep state, baby sleeping very quietly, like a really good sleep. And the baby starts to wake up, a more active sleep state. So the baby's becoming a little bit wiggly. They're still sleeping, but they are starting to move around a little bit. Maybe the baby's more than likely starting to get hungry, so they're starting to move around a little bit. Then the baby is drowsy, quiet alert. Then the baby is active alert, like hurry up, where is my food? I'm not, you know, get moving, people. And then the crying state where the baby is crying, actively crying, okay? So again, from one state to the other, but not jumping all over the place. If a baby's jumping all over the place, that's a neurological issue. So first of all, you want to make sure that you didn't miss something in your assessment. Maybe the baby is going through the states, but you did not assess that. You did not, or you missed something. You weren't assessing closely and you missed a state, but you want to make sure that the baby is going through the states. Okay. I think that's about it. So the quiet alert state, this is the best time for the baby to spend kind of that bonding and attachment or attachment time with the mom. The active alert state, by here, the baby's really hungry and is like, I need to be fed, okay? I think that, So again, behavior is indicative of central nervous system function. You want to consider the periods of reactivity because that will, and adjust your care accordingly. Behavioral changes, orientation. This is the baby's ability to pay attention to auditory or visual stimuli. So the baby is oriented to the mom's face. The baby is oriented to the mom's voice. Very prominent, as I said, during the quiet alert time, the time that you want the baby to have that attachment time. That's when the baby's really going to orient to the mother, to the caretakers. Habituation. I'm sure that you have all seen a baby that is sleeping in a brightly lit, noisy room. That is basically habituation. So initially babies will startle or they will respond to stimulus, but over time, all of that stimuli, they just shut it out. All of that noxious stimuli, they just start to shut it out. And so they will basically ignore it because responding to all of that stimuli uses energy. So a baby will just stop responding to it. That is habituation. Self-consoling activities, you'll see babies bringing their hands to their mouths to suck. They will position themselves in a flexed, what we call fetal position, to console themselves. Those are all self-consoling activities. And then we always want to be mindful of what the parent's response is to baby's behaviors. Are they responding? Are they responsive? Are they interacting with the baby? Are they not? Everything we talked about last week. Okay, so questions. All right. So I think we have enough time. We'll at least start the we'll start assessment of growth, and then we'll take a break. So we assess the neonate's size for their gestational age by plotting it on a graph, the graph of intrauterine development. So, and if an infant may be, a baby may be SGA, small for gestational age, LGA, large for gestational age, or AGA, appropriate for gestational age. AGA is not average, it is appropriate, okay, for gestational age. All right, so what we are looking for, AGA, is a baby whose size for gestational age falls between the 10th and the 90th percentiles. So you all have, I gave you this slide. So this is how the SGA, LGA, or AGA is determined. So basically 2 practitioners will do, either 2 practitioners or 1 practitioner, usually about 12 hours apart, will do 2 assessments and then document them. And we do 2 because we want to kind of verify what the findings are. And remember, a newborn's measurements, this is what's going to follow this baby until adulthood. So their pediatric growth, their growth and development as a child is going to be based on this. So it's important that we get this right, and it's important that it's confirmed. So does everyone have this slide that they can see it clearly?
Yes, I do.
So everyone should have this. Okay. So if you have, I want you to try to plot for yourselves a baby on the length. Okay, so let me just realized I didn't say something. So we do mainly 3 measurements: length, head circumference, and weight. Just looking. Okay, length, head circumference, and weight. I'm going to leave this quarter of the chart, the IUGR, until we get to complications, okay? Because it really doesn't apply to normal newborn. So if you have a baby who is 34 weeks, so 34 weeks, you find 34 weeks at the top, and let's say the baby is 43 cms in length, so you would find 43 here. And the line where that intersects, what would you tell me about the baby's length? Is the baby SGA, AGA, or LGA?
AGA.
AGA. So this down here, I mean, you're looking at it in color, at least on the screen. But if you're looking at it in black and white, I don't want you to get attached to the pink and blue and yellow. Remember that SGA is the 10th percentile or less, LGA 90th percentile or more, and ideally what we want is between the 10th percentile and the 90th percentile. Okay, so we have a baby who is AGA for length, and let's say the baby's head circumference, that same baby, the head circumference is 33. So if the head circumference is 33, I can't really see it. So if the head circumference is 33, what is that for the, where does that baby plot for head circumference?
AGA.
AGA still?
LGA.
No, it would be like in the 80th percentile. Because it was 34 weeks, right? Is that what you said initially?
It was 34 weeks.
Oh, 30, okay.
So it's about 80.
So it's 80th percentile.
Mm-hmm.
Okay. So it's the 80th percentile. So it's still between the 10th and the 90th, right? So the head circumference is still AGA. Okay. Now, the weight sometimes can be a little bit tricky because you have to still use the weeks at the top and then use the weights either here or over here. Okay, so we're still with our 34 weeker, and I'm going to make this baby 2,000 kilograms, my gosh, 2 kilograms, 2,000 grams.
AGA.
It is AGA.
AGA. Okay, so this baby is AGA for weight, for head circumference, and for length. So that is basically how you would plot this baby. So you would say this baby is AGA for all 3 parameters. So let me ask you, what if the baby was What if the head circumference was 27?
SGA.
SGA.
And so
That's
what's your
getting-
concern about this for this baby? Don't overthink it. You know this.
Preterm.
Development.
Oh,
Brain development.
great.
Brain. That's it. The brain is, the head is too small. What's happened with this brain development? Right? So when you're looking at the growth of the head, that's where you have to always be thinking about brain development. Okay. So this is a baby that will need, you would have somebody verify your measurements, verify that they get the same when they plot the baby. But this is a baby that would need to be followed by pediatric neurology to see if there's something wrong with this baby, why this baby's brain has not grown.
Hi,
And
this
what
is
does this
Victoria.
mean for this child going forward?
But so
I'm
what
sorry,
about
Victoria.
other side, like the other way? LGA
Yeah, you were
or
supposed to call me back that same.
Victoria, Victoria. Okay.
Carry on.
Professor, what about
Yes.
the other way, the head circumference, like LGA? Same thing is a brain, something wrong with the brain too?
Okay, so I'll give you an example. What if you have a baby? I'm not going to give you numbers, but let's just say, okay, let's say you have a baby whose length is LGA, the head and weight are AGA. What's your thought? The length is LGA, the head and the weight are AGA.
It's just, it will be tall.
Maybe it's
The
a
baby
big,
has a
it's a
big head.
tall, big baby.
So what's one of the things you would assess?
Maybe
The
some,
size of the baby's head.
maybe
So
some,
you already know that the head is AGA, the weight is AGA, the length is LGA.
is there something, there's something with like,
Don't
Yeah.
overthink it though. Don't make it complicated.
pituitary that they
No.
grow.
Don't make it that complicated. Don't make it that complicated.
I mean-
Remember, I want you to start simple. Start simple. So you have a baby that is long,
Long.
right?
I see the
You have
parent.
a long baby whose weight is normal and the head size is normal. Why might that be?
The mom is high.
Parents are
You
tall.
look at the parents.
Yeah.
Look at the parents. This baby might be born to a family they're all very tall and thin. They just might all be lanky, right? You look at, if there are siblings, you look at them. So again, start simple, okay? And work your way up. You may have, so what about the same thing? If you have a baby that is SGA for all three, it may be that there was a nutritional issue, but it also may be that the parents are just very petite framed people, right? That just may be. And so you have a baby that seems small, but is in proportion, and the parents are petite. Okay, so start with the simple. You might have to do more testing, but I want you to think about it in that way. Now, in terms of the head circumference, always remember when you're looking at the head circumference, you're looking at brain growth. So you always want that at least AGA, preferably 50% or more, because 50% or less, you might be heading in a direction that you don't want to go in, all right? That's going to need to be followed. So if the baby's head circumference is LGA and the weight and length are AGA, it's going to depend on what the difference is. So if this is a baby, let's say the head circumference is 100% and the weight and the length are 40%, that's way out of proportion. That's out of proportion, right? So you have to look at it in proportion. Look at the parents, but certainly look at the numbers in proportion, because the head growth may be excessive in that there may be some hydrocephaly. So there could be another problem on the other end, okay? So you have to put it in perspective. But this is how you plot a baby, and again, these numbers, this has got to be accurate, because whatever you put on this form, and this is something that we as nurses do, whatever we put here is going to follow this baby. And this is how at 3 months, 6 months, 3 years, 6 years, you know, all through pediatrics, and those of you who have children know what I'm talking about, the child's growth is going to be checked and verified based on this. So we've got to get it right. So questions?
Oh
Professor,
no, I was
Professor,
questioning about the you said hydrocephaly. Is the macrosomia is instead referred to a
I'm going to
weak
come back
baby?
to, I will come back to hydrocephaly. Palavina, you had a question? I think that was your voice.
The bottom right quadrant where it says weight length ratio.
Right. Remember I said IUGR will cover when we get to complications.
Okay.
Because right now we're just talking about normal,
Okay.
doing what they're supposed to do, little babies. Okay. So weight, we compare with the standards. We do our SGA, GA, LGA. So in general, a full-term baby should be 2.5 kilos to usually to 4 kilos. A baby that's over 4 kilograms will be considered macrosomic.
Mhm.
So we'll talk more about macrosomic babies when we talk about diabetes. But over 4 kilograms is considered a large baby, and we typically see that more with our babies that are born to diabetic moms. Okay, I will not ask you a question, you know, what is the normal head circumference of a full-term baby? I'm not going to ask you that, but I might have you plot a baby. I don't know as yet, but I won't ask you these numbers. So don't torture yourselves between, you know, for next week with memorizing these numbers. All right. Okay. So this nurse is doing a weight on a baby, and what method of heat loss has she taken action to prevent?
convection.
I'm sorry, say that again. I think that was Alice.
Yeah, I think it's
It's
convection
one
from a colder surface to the infant. So she's placed a blanket.
Right. So she put a towel, a blanket there, but that is conduction.
Conduction, sorry.
Conduction, yeah, direct contact. Remember, convection, like the oven, is airflow.
Right. Through there. Got it.
Okay. So yes, conduction. Here she's trying to stretch this baby out to get a length. I always encourage new nurses to get someone to help you, because that baby is not going to cooperate. So it's much easier when you have someone who kind of stretch the baby out and you do the measurement. Head circumference, being done right above the level of the eyebrows, all the way around the head, with the measuring tape held snugly. Chest circumference across the nipple line. Ballard scoring, you don't have to know, okay? I gave you the slide, but you don't have to know it. Pediatrics no longer covers it, to my knowledge. Well, I'll double check with the new professor, but I'll tell her we're not covering Ballard scoring. What I will mention is just a few of the things that can help you with determining whether the baby that you're assessing is term or preterm. So Ballard scoring, there are 2 sets of tests that are done, neuromuscular and physical characteristics. And then each component is given a score, the numbers are tallied, and that tells you the number of weeks of just the gestational age. Now, Ballard scoring, remember, we've talked about moms who have no prenatal care. They come in, they deliver a baby. How do you know that this baby is 36 weeks, 38 weeks, 40 weeks. You have to have some sort of assessment. So we typically will use Ballard scoring for that. So looking at these two babies on your screen, which baby is premature?
The one on
Or
the
which
right
one of the
screen,
babies premature?
the B.
Right.
So why is
B.
this, what makes you say this baby is premature? Now, you know, if you give me an answer, I'm going to ask you why, right? So I want you guys to start thinking about
Skinnier and less flexion.
It's all lanky.
it. So one at a time. Who was that? Fred, was that you or was that Zach? It was Zachary.
Yeah, I said the baby is skinnier and less. There's less flexion. There's less like muscle tone, less flexion.
So
just
go
kind of-
back to skinnier. I want
Okay.
you to give
You
me
can see the
another.
baby's ribs. The arm is
So I agree with you, but I want
Yeah.
you to just phrase that skinnier differently. So this baby has.
like the chest circumference is like the baby on the left. The A baby is like very full and taking a deep looking breath and like
So this
and-
baby has less muscle mass,
yeah.
right? This baby has less subcutaneous fat,
Mm-hmm.
right? So
Also
that
shallow.
so those are the baby has less, the baby has like no subcutaneous fat.
Yeah.
So yeah, that's important. The lack of muscle tone is important because remember, a baby that can hold themselves flexed, this baby is going to be able to hold temperature, hold his heat more. This baby's not going to be able to do that. Remember that flexion positioning conserves heat. This baby's not able to do that, right? Okay.
Also, can the baby also be post-term?
Okay.
So yes, and a post-term baby, which I'll talk about when we get to complications because they've got their own little issues, they're able to flex. Even though they have some muscle wasting, they are neurologically sound and able to hold themselves in a flex position. So square window, babies that are term have a less of an angle when you do square window than the preterm babies. They have more flexibility, less flexibility. I know it looks horrendously painful, but it's not. It's not. It's you know, you do it gently. Arm recoil, again, muscle strength and tone. If you hold the baby's arms up and then you put them down, does the baby's arms recoil? Is the baby able to recoil her arms or not? This popliteal angle and heel to ear, both of these are basically looking at muscle tone, muscle strength, muscle coordination. And you can see this baby just doesn't have the energy, right? Doesn't have the muscle tone, doesn't have the strength to resist. Whereas this baby is like, you're just not pushing my foot any further. I'm not having any parts of this, right? The baby has the strength and the tone to resist. This baby doesn't. Okay, scarf sign. I want you to look at the point. Whoop, sorry. I want you to look at the point of the elbow and think about where the point of the elbow is. This term baby, the left arm, you can see even from the facial expression, the baby's like, you're not going to pull my arm any further. The point of this elbow is right about at the left nipple line. Now this baby, it's the opposite arm, but still it's the right arm, but the elbow, the point of the elbow is all the way almost to the left nipple line. This baby doesn't have the muscle tone or the muscle strength. This baby is fighting, right? This baby is resisting the movement. This baby doesn't have it to do that. So you can tell. So these are some of the tests that are done. Now, the next few that I would will discuss, even though they're part of the Ballard assessment, I expect you to know them, okay? These are the easy ones. These are the simple, don't have to be scored, and you should know these, all right? So, plantar creases. Prenatally, when a baby starts to develop creases on the sole of the foot, they start at the heel. I'm sorry, they start at the boil of the foot, and the creases advance towards the heel. So they advance towards the heel and they become more pronounced deeper into the foot. So you can look at this baby's sole and see this is a preterm baby. There are no creases here, no creases. And you can see that the creases that there are, these creases, they're not as deep as these. So as soon as you look at a baby's foot, you should be able to tell. This is a term baby, this is a preterm baby. So let me know in the chat box what you think about this question, A, B, or C, or D. A, B, C, or D. Whoops. Oh, stop doing that. Just put it down for now. So I'm seeing lots of B's and D's. So yes, the baby has to be footprinted. Heel sticks may be required. Heel sticks are how blood is drawn from a baby's foot. We'll talk about that in a few minutes. But the question is, as the skin dries, do the creases become more prominent or less prominent? So I think more of you said it will become more prominent, and yes, it will. So the answer was B, the skin, the creases will become more prominent. And so we want to get the, to do the evaluation before any changes occur, so that we're really evaluating this baby's gestation, okay? Before extrauterine life changes what we're dealing with. Okay, so plantar creases, ear recoil. So cartilage is laid down in the last trimester. So babies that are born prematurely might not have cartilage in to their ears, and sometimes it might still be not as pronounced even in their noses. So that will have to develop over the first few weeks of extrauterine life. With the term baby, if you fold the ear forward, it will recoil right back. You can see this preterm baby, you can see just looking at it how flat it is. There's very little cartilage here. Okay, so plantar creases, ear recoil, and then genitalia. So near-term infant, the labia, and certainly definitely with the term baby, the labia majora pretty much cover, provide full coverage, okay? With a preterm baby, you can see the labia majora do not cover, do not provide full coverage, and the clitoris is more prominent than what you will see in a new near-term baby. In our males, I mentioned yesterday about the testes descending at about 36 weeks. So whether or not they are present in the scrotum is one of your indicators, but also whether or not there are rugae, these folds on the scrotum. You can see that this baby is very, the scrotum is very smooth. It doesn't have the rugae. Okay, so that's one of the other things that you're looking at in the male. Plantar creases, ear recoil, and genitalia, 3 really easy ways to get a feel for whether or not this baby is full term or preterm. So this is just what a Ballard scoring form looks like. I think we talked about all of this. So depending, as I mentioned before, on what you get from the age and sizing from the charts, from the growth chart, from the Ballard scoring, you might need to do further testing and or monitoring for complications. All right, so that's growth. Are there any questions before we take a break?
We're doing nursing care of the normal newborn next, right?
Yes.
Okay.
Okay, if there are no questions, then we'll take a break. We'll come back at 5 after 11, please.